He'll come back in. There's a question. Hi, good afternoon, everyone. This is Dana Harganani, Chief Medical Officer for the Oregon Health Authority, joined by my colleagues, Dr. Tom Jean and Dr. Ariel Smith again. We're glad to be here with you today. And we have, I think, a fairly packed agenda. So we'll go ahead and get started. As a reminder, we won't be able to answer your questions real time given the format and how we're set up here on Tuesdays, but we do encourage you to go ahead and put your questions in the chat box or send us an email with the questions. We'll give you the email address again at the end of this webinar. We will make sure to look at those and try to capture answers to those questions at our next webinar. So without further ado, we will walk you through our agenda for today. We'll go through some of our normal epi and hospitalization data with a few new slides that are hopefully helpful to you. Then probably on top of everybody's minds are the governor's public or news conference regarding reopening and information on the website about some of the criteria and what that looks like. So we'll walk through some of that with you today. We're also going to give you an update on immunizations during COVID-19 and some of the impacts to what we're seeing with ordering and rates of vaccinations during this period. We're going to talk briefly about what we're learning about asymptomatic COVID-19 transmission. We'll briefly give you some information about OSU's Trace COVID-19 project. This is not our project, but we get a lot of questions about it, so I want to make sure you knew where to look for that information. And then finally, we're going to close with a little bit of information about the Pediatric Multisystem Inflammatory Syndrome, which you might be reading about in the news. Primarily on the East Coast, and finally answering a couple questions we've received before we close. So getting started, here is our EPI update. So this is data as of yesterday. Yesterday we had a total of, cumulative total of 3,222 positive COVID-19 tests reported to the Oregon Health Authority. We've had a total of 130 deaths now. And 74,320 negative tests. You will see on our website, as we've spoken to before, we are also now reporting on presumptive cases, which are not represented on this slide today. And I'm going to pass this to Dr. Jean.
Thanks. So here's our table of our testing results, updated for last week's data. And I'd call your attention to two things. So for the most recent week, May 2nd to May 8th, we did see an increase in the number of positives, but also a big increase in the number of negative tests. So we are now up to a total of almost 15,000 tests per week. And you can see that has steadily increased, especially in the past 3 weeks. Good news is the percent positivity for these tests is continuing to decrease and currently at 3.1%. Let's go to the next slide. Oh, and then I would also add that, our cumulative positive testing rate has been about 4.2%, which is quite a bit lower than the national average, which is currently at 17.0%. So for the epi curve, you're noticing here that we seem to have plateaued a bit in terms of our case counts overall, and this is by date of symptom onset. But I would call your attention here to the blue bars, which are showing a steady decline in hospitalizations. So this is consistent with the previous slide and our general increase in testing. So we are capturing more of the mild cases, but this is consistent with a decrease in severe cases, and probably the flattening of the overall case count is because of increased testing and finding more COVID-19 that's out there. For our daily ED visits, we've seen a steady increase, quite gradual for over a month now. So no change there really.
And Dr. Jean, I just wanted to follow up on a question we received about this particular graph. And the question we received was, what is our suspected reason for the drop in non-COVID visits to the emergency room in mid-late March? And then what do we think is the cause for the gradual increase? And I'll share some of my thoughts and see if my teammates here have any additions to this. Anecdotally, I would say we have a lot of information hearing from people and from hospitals that people seem to have been concerned about perhaps going to the hospital and trying to avoid it if not necessary as part of the reduction in the cases. We also know that there are things like reduction in transmission of other infections like influenza because of the stay at home, save lives approach and physical distancing. And furthermore, things like traumas were likely lower during this time. I don't have data at my fingertips to display that to you, but without so much traveling and transportation and other activities, again, suspect that those are related to the decrease. I guess commensurate with an increase we're noting in traffic outdoors and data to support that. There are more people out and about now. Again, we've been trying to continue to share the message of the importance of physical distancing, but we expect that some of the increase in visits gradually recently may be related to some of that increased movement happening. I'm going to look to my colleagues if they have any other comments to share.
Nothing to add. That's a great summary.
Great. We'll move on then.
Yeah, so with that in mind, it's still reassuring that we are seeing about a 1% rate of ED visits for COVID-like illness. So that hasn't really been increasing. That's been pretty steady for the past couple weeks. So here's just an updated slide with our signs and symptoms. These are taken from the case investigations that our local public health epidemiologists do for every confirmed case. We're now up to over 3,000 of these. And there's the gray bars in the middle there are now reflecting the unknowns. We haven't been able to get every question answered on these interviews always, but you can see that cough, muscle aches, headache, fever remain the top symptoms. And of note, we had about 6.2% of people who did not report any symptoms. So presumably that reflects the testing of asymptomatic people that has been happening at some level.
So this next slide again is the information from our hospital capacity or HOSCAP data system, and this is daily reported information from our statewide hospitals on their current COVID-19 hospitalizations. In the far right column, you'll see these are the currently hospitalized patients who have known positive results. So currently across the state, as of yesterday, there were 59 hospitalized patients with positive COVID test results, 16 of those in the ICU, and nearly all of those are on ventilators. On the left-hand column, these are patients who include both the positives, but also those with suspected COVID-19, and you can see the numbers, how those reflect here. We did receive a question about why this number on the left was so much higher, and does that have any relationship to or concern for false negatives? And I just want to state that no, this left-hand column doesn't tell us anything about false negatives. We know that this is a moving data point in that as patients are hospitalized, they may not have a test yet. They might have symptoms suggestive of COVID-19, or there might be a test underway. And as they either become positive, they would move over to the right-hand column. If they have a negative test, then they should drop out of this column of data. So that is generally the movement you might expect. We do know that there are a fair number of hospitals now who are doing pre-procedural testing on patients, even those who are asymptomatic. We've been working to better define this data field really so that it hones in on patients who are really suspected of having COVID-19, not just pre-procedural testing, but we do anticipate some of those fall into this category as reported by hospitals, so that again, once their test comes back either negative or positive, they would move out of this column and either to the right or off of this data point. I think it's useful to see, as I've mentioned before, some of the trends in these data points. So this is that left-hand column. This is representing confirmed and suspected hospitalized COVID-19 patients since we started collecting this data back over a month ago now. This nicely aligns, I think, somewhat with the epi curve that we're looking at in terms of perhaps expectations for more severe cases that require hospitalization. Again, this is the confirmed or suspected graph. And if we look at the next one, this is the positive patients. Please note that the numbers on the axis are different for each one, so please take a close look at that. But again, this represents fairly consistent decline in hospitalized COVID-19 patients, aligning with some of the other data points that you've seen that we just showed. You can also see on this towards the bottom showing the decline in patients requiring ICU beds or on ventilators. Again, consistent with the point in time data I showed you just previously. All right, we're going to move into talking about reopening of Oregon. I just want to let you know that all of the information I'm sharing with you here is listed or posted on Oregon's reopening materials site. This is on our coronavirus page. And there, if you go on the main page, about midway down, there is a tab around Oregon's reopening, and all of the information shared here comes from the slideshow that are represented there. So again, Governor Brown announced the plans for phased reopening at her May 7th press conference, which you can also find online. And she outlined the goals for reopening, as you can see here, including things like minimizing the hospitalizations and deaths, allowing people to return safely to work, minimizing risk to frontline workers, ongoing goal to avoid overwhelming hospital systems, protecting those at highest risk of illness, and allowing some support for small local gatherings that preserve community cohesion and cultural practices. So there were some statewide reopening announcements that were made, and here they are updated on this slide. As we've talked to before, the first kind of step in reopening was related to non-emergency and elective procedures, which were allowed to resume as of May 1st, last Friday, if the criteria could be met, for example, around PPE and hospital capacity. At the governor's announcement last week, there's also an announcement about reopening some recreational areas where physical distancing can be allowed or followed. Again, this is statewide. This is not to mean that all recreation areas were reopened. For example, I think the governor indicated that, for example, the beaches are not ready for visitors, and really still recommending to try to stay, to reduce or limit any travel at this point. And then starting on Friday, May 15th, announcement for statewide kind of opening around standalone retail that had been previously closed according to the governor's executive order 2012. But can now reopen starting Friday with, if they can follow OHA guidelines. So this includes some furniture stores, art galleries, jewelry shops, and boutiques that had been previously closed. Also, there's some forthcoming specific guidelines, but again, movement towards reopening with guidance, childcare, summer school camps, and youth programs. Again, still all of this guidance specific is not quite yet up, but will be forthcoming here very soon. So those are the statewide updates. Also announced by the governor and represented in the documents on the website is a move towards phased reopening, whereby some counties will be able to enter phase 1 as early as May 15th. The governor began accepting applications from counties for phased reopening last Friday, and I believe now that 32, nearly for sure over 30 now counties have submitted applications, and all of those can be visible online on the website. For counties whose applications are accepted and they are allowed to move into phase 1, I've shown you some examples of what phase 1 reopening looks like. This allows for some local gatherings, but only up to 25 individuals. Again, no travel. Some allowance for the reopening of restaurants and bars, and as well personal services. Each of the sectors will have specific guidance around reopening posted on the website, some still forthcoming. Looking ahead, there are not further details at this point, but just to give you an idea, The intent for phase 2 would be that it wouldn't come until after 3 weeks of being in phase 1, and that counties would be required to continue to meet the prerequisites of phase 1 before moving forward. More details to come on that. Some of the prerequisites to which counties had to respond to in their applications are listed in the next 2 slides. Again, I invite you to go to the web for further details should you want more information. The first prerequisite is a declining COVID-19 prevalence. This is based on statewide data that we have and can be measured at a county level. So both hospitalizations and as well emergency department visits for COVID-like illness, which we've been showing you during these webinars. There's also expectations for minimum testing regimen that need to be met, as well as expectations for contact tracing system in place. And these are all part of the criteria that counties need to respond to as part of their reopening application. The additional prerequisites are shown here, requirements around availability of isolation and quarantine facilities if were to be needed. We, of course, are working, as I mentioned, to finalize and produce statewide sector guidelines, which will need to be followed. Similar to the elective procedure requirements for reopening, there also needs to be an ongoing capacity to manage a 20% increase in COVID hospitalizations across a region. And then again, sufficient PPE supplies, some of which for hospitals, again, are similar or the same as the resumption of elective procedure guidance. So that's a lot of high-level information. Again, more of these sector guidelines and specific criteria you can see already or upcoming soon in the next couple of days on the website under the reopening tab, and we definitely invite you to go see that. There will be also, again, ongoing information on the website about the county applications and status of those. Moving on to a different topic. This is an important one that we wanted to make sure healthcare providers across the state are aware of, and this is related to the current status of immunizations during the COVID-19 pandemic. We wanted you to be aware of and recommend that you take a look at the CDC's recently released MMWR report on the effects of COVID-19 pandemic on routine pediatric vaccine ordering and administration. And the CDC data that's displayed in this report shows that since the March 13th declaration of a national emergency due to COVID-19, there's been a concerning decline in both ordering and corresponding administration of vaccines, as that can be monitored through a couple different sources of information that the CDC has. All of these are more explicitly outlined in the MMWR publication that we have posted here, where you can find that. But just as an outline, the CDC found notable decreases in orders for VFC funded or vaccine for children funded and recommended non-influenza childhood vaccines and for specifically measles containing vaccines. There were also similar declines in orders for other vaccines observed during this period since March 13th, and also a corresponding decline in administration of those vaccines, and specifically they looked at administration of measles containing vaccines. This decline was noteworthy more for those kids over 2 years of age, but differences seen across the board. In response to this MMWR, actually not in response to the report, but in response to similar data that was being noted here within our own vaccine program, our immunization program at the Oregon Health Authority conducted a survey among clinics who routinely provide immunizations to infants and children. These, again, are those who are enrolled in our Vaccine for Children program. And the survey was administered between April 18th and 29th. The full report of that survey can be found on our website. And again, I've provided the link here. Just high level, and I expect that this is not surprising to many people on the phone, especially those of you who have faced similar impacts to your practice. But 95% of those who responded to the survey reported changes in their immunization practices during these since the COVID-19 pandemic. 65% reported reducing or limiting well-child visits, and 5% canceling all well-child visits during this period. Half of the respondents reported canceling or rescheduling immunizations that were due for older children and adolescents, and the majority of survey respondents report difficulty maintaining staffing. We know that there are a tremendous amount of pressures and impacts on primary care practices across the state. Many of those, again, can be seen throughout the survey. It is really important, as you know, that vaccines continue to be considered essential during this time. We strongly encourage to ensure that children and adolescents are getting the vaccines they need. We acknowledge the challenges that practices are having and to be able to do that. And our immunization program is continuing to work with our practices and partners on how we can support them. We certainly know that a number of practices are working towards kind of recall opportunities in the near future to bring patients back into vaccines, and that will be a really critical approach to making sure we aren't faced with other infection control challenges as a result of COVID-19 response. Please do go visit the survey and the CDC report. All right, I'm going to pass this off to Dr. Schmitz, please.
So one of the questions that we got after last week's webinar was about asymptomatic COVID transmission, just kind of some general questions about what's going on with that. And I wanted to point out, I don't have the nice link that Dr. Haganani put in for hers, but MMWR published a report on May 4th. And it was looking at all types of data that they could find in the medical literature about supporting the idea that you may have asymptomatic would be a person who never develops symptoms but might transmit, and pre-symptomatic would be a person who eventually displays symptoms but transmits in the period before they develop symptoms. So they looked at 3 different areas and felt that they all agreed. So there were 11 case reports that they found. Most of which are in China, which have the sort of question about whether or not they were really asymptomatic or pre-symptomatic, or whether it was just sort of so prevalent in the community that there may have been another exposure. The ones that they put more weight on were reports from Germany and Singapore. They had very low community transmission, so these almost definitely were either asymptomatic or pre-symptomatic transmission. In these studies, the pre-symptomatic patient appeared to be able to transmit COVID between 3 to 11 days after their known exposure, before they themselves became symptomatic. So that was one piece of data that the CDC was looking at. They also looked at the data looking at culturing virus, and they did find virus that appeared to be infectious that they could culture from asymptomatic patients in several different studies. And then they looked at modeling studies that could not account for the speed and extent of the way that the SARS-CoV-2 virus has been spreading unless you do account for some asymptomatic spread. So they looked at kind of those 3 different threads and concluded that there was pretty good evidence at this point that there's either asymptomatic or pre-symptomatic spread. And then they recommended that based on this, there was several things that the medical community should be aware of. First, good news, the case fatality rate for COVID-19 is probably lower than what we recommend because we are not catching a lot of patients out there who have some type of infection. But also secondly, that while you're asymptomatic, you don't have fevers or other symptoms that can be screened. So that other things need to be put into place in the community to slow the transmission, which would include physical distancing, cloth face coverings, etc., and universal masking and healthcare. I know a lot of the health systems in Portland are doing universal masking, but according to the CDC would encourage all healthcare providers' offices to do that and to maintain the physical distancing. They also noted that this asymptomatic transmission data enhances the need to scale up the widespread testing and contact tracing to find these undetected transmission chains in order to bend the curve downward. So just be aware of all of that data.
Great. As I mentioned, we are going to share briefly about Oregon State University's Trace COVID-19 project because we do get questions about this, and we wanted you to be aware of their recent press release. We provided the link to the press release here as well as to the full study website, and would encourage you to reach out to OSU if you have questions about their study. But based on their press release, we wanted to share that their first week's results suggest that 2 people per 1,000 in Corvallis were infected with SARS-CoV-2. Within their project, they had 16 2-person field teams that visited 237 households in this first week among 30 U.S. Census blocks in Corvallis. 80% of people were contacted by field workers opted to participate in the study, and there was a total of 455 people that were tested. Participants in this project or study are given a nasal swab test kit that they self-administer, and also are given the option to administer to their children if they wanted them to take part. Again, would encourage you to reach out to OSU, look at their website if you have further questions. We've been certainly monitoring this as another important set of information to help us understand the impact of SARS-CoV-2 in our state, and obviously particularly here in a focused region of Corvallis. Back to Dr. Smits.
So we've got some questions about a new disease entity. I kind of been saying that in quotes. We're not quite sure what this is. There's a new condition that's been tentatively named Pediatric Multisystem Inflammatory Syndrome. I'm sure you've been seeing this in the news, and I know we did get some questions about it. So this is a very new syndrome that has appeared, and there's really no agreed upon case definition. New York State has just made it reportable, and so their case definition would be a child with a persistent fever, and this is usually 5 or more days of fever, and then they have some signs of inflammation, such as elevated C-reactive protein or neutrophilia, and then evidence of single or multi-system organ dysfunction. And then no other cause, bacterial sepsis or toxic shock syndrome, those things, nothing else could be used to explain the symptoms that the child has. This is a moving case definition. Like I said, this is New York State's version. The Infectious Disease Society, the Infectious Disease Society of America and other groups still don't really actually have a case definition because this is too new. This does overlap with Kawasaki disease and toxic shock syndrome, but does have features that are different from those. So kind of somewhere in a continuum. One of the important things to know is that we're not sure if this is related to SARS-CoV-2. The majority of patients tested positive, although many of them had actual just antibodies and not PCR positive, making the kind of the theory that this might be some type of an autoimmune reaction after infection. Most of these cases are being seen in Europe and on the East Coast. There is one suspected case in Oregon currently that OHA is aware of. So something to just keep on your radar, but to realize that it's pretty low case numbers here. It's not reportable currently in OHA.
Right, and we're discussing, this is Dr. Jean, we're discussing the case definition because at this point, the proposed case definitions, including the New York State definition, are quite broad, as you can see. And so we have to figure out a balance between capturing all the potential cases and having a specific enough definition that we can actually identify it as a real unique syndrome. So we'll continue to discuss.
So this is a recommendation from Boston Children's Hospital about kind of working up these types of children. So again, these children have unexplained fever and evidence of inflammation, and they need to be followed very closely because some of these children have very quick progression of disease. You can see on the slide there the laboratory tests they recommend, basically looking at inflammatory markers, CBC, liver function, and cytokine panels. And they should have both PCR testing for SARS-CoV-2, and if they're negative, then they should have antibody testing. Also, they should have serial echocardiograms because one of the main issues with this syndrome appears to be heart function issues. It's separate from Kawasaki. It does possibly involve the coronary arteries, but sometimes it actually involves the heart itself, more like a heart failure types of things. And so just to be aware, if you run across any cases, hopefully you won't, but this is just some information about the sort of workup. Next slide. And then the treatments that have been used in the New York area, Boston area, et cetera, are IV immunoglobulins, corticosteroids, IL-6 blockades, et cetera. Some kids do fine with just supportive care. Another point here, this is much more common on the East Coast. There is a slightly different strain of SARS-CoV-2. You've heard us talk about that on previous calls. It doesn't appear to have anything to do with the infectivity of the disease, but again, this is a brand new syndrome. People are trying to sort it out. They're wondering if that strain might be more likely to cause this syndrome, but that is unknown at this point.
It's also very possible that it's people are talking about it more on the East Coast, and so people are looking for it and finding it more.
Higher infection rate in general, so you're going to get more post-infectious complications. So the take-home points: this is super rare. Keep an eye out for it, but it is something that we don't have very much of at all at this point. If you do suspect a case, promptly consult your local pediatric infectious disease or critical care specialist. These kids should all be cared for in the hospital that has an intensive care unit because they have the possibility of getting sick rapidly. And also to be aware that that if a kid is SARS-CoV-2 PCR negative, that does not rule it out. So just be aware. Again, super rare, and hopefully will stay rare in our area. Moving on to clinical care questions. These are the questions that you guys submitted to the chat box or an email last week. There's some questions about return to work guidelines. So in general, these are, would be a grocery store worker or some other essential worker who's not in healthcare. The person who in this case is sick with COVID-19, they need to have had no fever or cough for 72 hours without using any medications that could reduce fever. This applies to everybody for any type of illness. Hopefully, hopefully you have good sick leave for your employees, and they do not need to return to work until they have had a good time to not have a fever and not respond. Then there's a question about healthcare workers who tested positive, but they're asymptomatic. So we know that some systems are expanding their testing, and then there's been some asymptomatic testing going on. If a healthcare worker is asymptomatic but has a positive test, they should remain in isolation at home for 10 days after the positive PCR before they return to work. And again, this would be the case for any asymptomatic COVID. So the case that we had just talked about return to work, that's for people who have symptoms. If they don't have symptoms, they should stay home for 10 days after their positive test. And then what do you recommend for individuals who have no medical provider who have a COVID-like illness? There's no wrong door. These people can call 211, OHSU COVID hotline. They can go to local ERs or urgent cares. They can go to a safety net clinic. They can go to their primary care. They whatever care access they have is the best access for them.
I was going to add a couple questions we didn't get onto a slide, but that we did receive. I'll just speak to them. One question was, are there specific facilities around Oregon that have been designated to see suspected COVID cases with severe symptoms requiring emergency or inpatient care? And similar to Dr. Smith's answer just now, the answer is there's no wrong door. There are not specific facilities. We would encourage people, especially if they have severe symptoms, to seek emergent care as soon as you can. Ideally at an urgent care or at an emergency room that you can get access to, or through conversation with your provider on where the best place to go. Certainly, we know that all of our hospital facilities are seeing patients with COVID patients. Certainly, if someone has a critical care need that can't be managed at that particular facility, that they access care, then that hospital can support the transfer to a hospital that can manage their level of care. But there are no specified facilities at this time, and we would encourage people to get to the closest place that they can to seek care.
And just one add-on to that, if you are talking to somebody, if they've called your clinic or something and they have COVID-like illness, just make sure that you have the person alert whatever place they're going that they might have a COVID-like illness, so that they can have appropriate triage and masking and isolation, etc.
And then one other question was related to guidelines for monitoring at home. And I'm sorry we didn't have the link up here, but we do have on our COVID coronavirus webpage, homepage for healthcare providers, we do have information about home care and home monitoring. I believe we link you right to the CDC website for guidance there. So we encourage you to take a look there as a resource for how to support individuals who may be doing home care and not needing to access healthcare services at this time. Anything you all would add? Okay.
I guess I would add a couple random things from previously. So the website that has the counties on it is the governor's website, and you can get to that by going to oregon.gov/coronavirus. And all counties except for the Tri-Counties in Portland area, Multnomah, Clackamas, and Washington, and Lincoln County. Those are the 4 exceptions. All the other counties in Oregon have already applied, and they're under review.
You can also find those through a link on our website too. You'll find it in multiple ways.
Great. And then about the TRACE study, I can't recall if Dr. Smits mentioned that it was a PCR test, so it kind of makes sense that the prevalence was very low. We're looking forward to some of the antibody testing to see how many people have already been exposed and don't currently have the virus. That'll be informative.
And, you know, the TRACE study is just one effort underway in Oregon that tests asymptomatic patients. So that includes, we've talked to before, the OHSU study that will include a subpart of enrolled individuals who will get testing regardless of symptoms, as well as some of the work we're doing through our surveillance strategy ahead that will include some asymptomatic testing as well. So again, we're seeing an increase in our testing capacity, as well as further testing of limited symptoms or asymptomatic patients that will give us more and more understanding about the presence of SARS-CoV-2 in our state. Okay, we are going to close. So we again point you here to the healthcare provider website that has the HCP on the end. Just to remind you, there is a section on this website that relates specifically to these webinars where you can go and look at previous slides or listen to the previous recordings of these webinars. Again, we encourage you to send us your questions. We appreciate them. They're coming through at a regular pace to this email address. Please know that we can't respond directly to all of them. But we will try to capture a response to your questions in these webinars. And again, a reminder, please not to send personal health information regarding yourself or other patients you may be caring for. And then as another reminder that we will have ongoing Project ECHO sessions weekly on Thursdays through May. So there will be another one at noon. This format allows for more interaction and real-time question answering, both by your colleagues and experts who are joining the webinar. So we encourage you to join us when you can. And we again want to say thank you for all the work you're doing. This is a dynamic, changing environment, as we've tried to keep you updated on, especially today with some of the reopening information that the governor has announced. And we invite you to keep sending us your questions, and we will commit to continuing to bring you this information. So thank you for all that you do. Stay safe, encourage continued physical distancing, even throughout reopening, and we look forward to talking with you again soon. Thank you.